Good evening, all the esteemed members of Maharashtra Ophthalmological Society and all our members who are also joining from the other states from All India Ophthalmic Society. We welcome you on behalf of Maharashtra Ophthalmological Society, which is currently the largest state society of India. Maharashtra Ophthalmological Society has been also actively one of the most scientific societies that we have in the country and has always led from the front when it comes to new initiatives and creating new landmarks in Indian ophthalmology. Team MOS is today happy to introduce a very exciting new initiative, which is legendary masterclasses. Meet the MOS Legends, wherein the living legends themselves will take us gently by their hand to see us through in their clinical, surgical, and life lessons that they have learned through their very long and illustrious careers. And to have the opening first episode, we have none other than our own legendary Professor Dr. Keki Mehta sir, who will be talking to us today and helping us, illustrating us with all his surgical, clinical, and life pearls. So we welcome all of you on behalf of MOS for this legendary masterclass. Before we go on to the actual episode, uh, we all know that Indian ophthalmology has lost one of its most illustrious figures that we have had ever in our, let's say, clinical ophthalmic uh, world. Padma Bhushan, Dr. S.S. Badrinath sir is no more, and sir has passed away today. And to we all, the ophthalmologist of Maharashtra, of All India Ophthalmic Society, and especially the Shankar Nitra alumnus, uh, we feel this as our personal loss. Padma Bhushan, Dr. S.S. Badrinath sir, has been a distinguished luminary of Indian ophthalmology and has been celebrated as the pioneering force behind the renowned Shankar Netralaya in Chennai. He has been revered affectionately as the chief by all his mentees, including me and Dr. Santosh Agarwal sir. Both of us have been alumnus of Shankar Netralaya. He has always embodied the visionary spirit that has reshaped the landscape of ophthalmic care in India. Dr. Badrinath sir's vision was far beyond the horizons. His unwavering commitment to excellence, strategic prowess, exceptional clinical and surgical skills, insatiable thirst for knowledge, selfish dedication for training and mentorship, openness to innovations, boundless creativity, and unyielding ethical standards, all bundled in steely self discipline, collectively distinguish him as an unparalleled leader that we have ever had. As we mourn the loss of this luminary today, let us honor his memory by embodying the noble values and the principles he championed, weaving them into the fabric of our patient care, training, and research pursuits. So, on behalf of Team MOS, we feel uh, that it is our personal loss, and I would like to request everybody to please maintain 1 minute silence in memory of Professor Dr. S.S. Badrinath. Thank you. So, to begin with our first episode, first I would like to invite our chairperson, our president, very dynamic Dr. Santosh Agarwal sir, to give his welcome address. Over to you, sir.
Thank you, Vardhaman. Respected Dr. Kiki Mehta sir, Miniar sir, Prakash Kankriya sir, and my dear friends, colleagues, and all audience. I am extremely happy today to have Dr. Kiki Mehta, who is a very distinguished visionary leader of ophthalmology, who is going to participate and share his experiences with us. And this legendary figure is going to talk us regarding his experiences, whatever he has experiences in his surgical skill as well as in his life, in his practical sphere. He will share with us the do and don'ts, tips, the pearls of wisdom, and that will definitely help us in our day-to-day practice, as well as our novice surgeons and the newcomers who will learn from him. And we are very fortunate to have him today. Sir, you are a pioneer in ophthalmology. You are a Bhishma Pitama of ophthalmology. Actually, in different conferences, I was used to listen to him, and I just eager to know from his talk what next or new things he is going to come out with, because he always is a innovative person. He come out with new technologies, new methods of surgery, and is a very distinct personality in ophthalmology. Sir, we are very eager to hear to you and learn from you all the tips, whatever life experiences you have, and very much we are fortunate to have you today here. So thank you very much, sir, for taking our invitation positively. And over to Vardhaman, please.
Thank you very much, sir, for addressing all our members and welcoming our luminary legend, Dr. K.K. Mehta, sir. So herewith, I have the privilege and the honor of introducing our legend today, which is none other than Padma Shri Professor Dr. K.K. Mehta, sir. Dr. K.K. Mehta, sir, of course, is a renowned Indian ophthalmologist, not only in India, but also all over the world. He completed his medical schooling from Christian Medical College in Ludhiana, DO from Amritsar Medical College, and MS from the PGI MER in Chandigarh. He subsequently did both his DO in London and DO in Ireland prior to returning back to India. Professor Mehta pioneered many new eye surgeries, and he is known as the father of Indian phacoemulsification. He performed the first intraocular implants in 1972 and also started phacoemulsification since 1989. Also, one of the pioneers of refractive surgery in India. He developed world's first HEMA soft intraocular implants in 1976 and has developed multiple instruments and surgical devices in especially in cataract surgeries. He's the past president and the past chairperson of the scientific committee of AIOS and past president of Intraocular Implant and Refractive Society of India. He has been also the past president of the Bombay Ophthalmic Association as well. Professor Mehta is chairman of the Indian Academy of Ophthalmology and runs extremely popular eye advanced congresses that have been honored, and I have had several occasions being a part of this amazing conference. He is, of course, a surgeon par excellence with outstanding surgical skills and the most innovative surgical techniques with an extensive experience of operating more than 2.5 lakh cataract surgeries in his lifetime. He is a surgical director and the chief at the Mehta International Eye Institute. He is always on cutting edge of technology, doing the latest and the most advanced surgeries. He's the first to perform advanced robotic cataract surgeries with Catalyst. He's one of the pioneers and one of the first people to start smile surgeries. He has been the professor emeritus at D.Y. Patil Medical College and also at the Breach Candy hospitals. He has been awarded several major oration lectures and awards in India, and he has been conferred honorary fellow of AIOS as a mark of respect for his pioneership in cataract and phacoemulsification surgery. He has been recently awarded with the International Ophthalmic Heroes of India by our coveted AIOC in New Delhi recently. He has received the topmost international and national awards from all over the world, and his international awards and prizes include Outstanding Researcher Award, which was given by the National Eye Research Foundation in Chicago, American Implant Society Appreciation Award, the Leam International Award given by APAO, the Outstanding Recognition Award, which was presented by the Cataract Surgeons Association of Barcelona in Spain, Outstanding Innovative Surgical Video Award by APACRS, the Legion O Honor, which is given by the Barraquer Institutes, and he is the only Indian to receive the same. He has been given the Outstanding Researcher in LASIK Award by the German Foundation. The Lifetime Achievement Award was given to him uh, by the Innovators segment. He has been given Antonio Scarpa Award which is the highest honor given by the European Ophthalmic Society. The Triple Ribbon Award, which was presented in Atlanta, USA, for outstanding research presentation, which was done during the ASCRS in 2014. Sir has received ASCRS Grand Honors Award, the Scientific Life Work Award. Sir has been presented with Surgical Excellence Award, which was given in 2018 by the Swiss Ophthalmic Society, the Award of the British Ophthalmic Excellence in Ophthalmology, the Scholl Oration Award, which was given by the Hungarian Cataract and Refractive Surgeons Society, Innovations in Ophthalmology Award, which has been given by by Poland Ophthalmic Society, Presbya Mini Award by the Presbyopic International Society, which is in Poland. In addition to that, sir has been given the most coveted award from Indian government, which is the Padma Shri, which is one of the highest civilian awards that is given to a citizen of India for his lifetime of work as a expert eye surgeon. Sir has been given several eye national awards and gold medals by variety of societies, including the Mayuri Lal Gold Medal by the Madras Ophthalmic Society, Rajiv Gandhi Gold Medal by Bombay Ophthalmic Association, late Dr. V.K. Chitnis Oration Award by MOS, Professor C.H. Krishna Award by AIOC, Dr. B.S. Pense Memorial Award and Oration given by Indian Medical Association, K.R. Datta Oration Award by AIOS, Ravi Bandare Award, which was given by Contact Lens Society of India in Mumbai. And there have been several other awards, including Dr. T. Agarwal Gold Medal, Dr. Om Prakash Award, Vascon Plenary Award, Anand Puri Oration Award, Exceptional Service to Ophthalmology Gold Medal Award, Outstanding Services in Ophthalmology Award, Excellence in Cataract Surgery Award, which was given in Coimbatore by during the FECO Refractive Society conference.
I think it will take whole night.
So basically, to cut short, sir has been, of course, such a luminary that including, I think if we just talk about sir's awards and achievements, it is going to take a webinar in itself. So I would like to now request Professor K.K. Mehta sir to talk to us and take us through this session is going to be divided between two zones. First, sir is going to share his pearls about clinical and surgical tips, which is going to be followed by the panel discussion, and that is going to be followed by the second segment, which is the life pearls by Professor K.K. Mehta. And also joining us right now are our Honorary Secretary, Dr. Adul Kadane, and Honorary Treasurer, Dr. Mandar Paranzape, Secretary to the Scientific Committee, Dr. Watwe as well. So over to you, Dr. K.K. Mehta, sir, for your first clinical and surgical pulse talk. Thank you.
I would like to like to thank Maharashtra State Ophthalmic Society for giving me the honor of talking on as the first, as one would say, awardee of the what should I say, leader awards, as one would go on. And I would like to thank very much Vardhaman for having considered me. Having said that, I'd also like to thank him very much for the very long introduction. As a matter of fact, at the beginning, all he should say, okay, I'd like to introduce Dr. Mehta, you all know him. That would have actually sufficed. But nevertheless, thank you so much. Today, I was told to go on to some pearls. And I'm going to take you on to some of the newer techniques which we have developed over a period of time and try and take you through them so that it will make your life a little easier when you are faced with the same problems which I had been faced with. Having said that, let me start.
1 second, Dad, can you hear me?
Yeah.
Vardhaman, the program is something else.
No. So basically, I spoke to sir.
It's been changed. Okay.
Yeah,
all right.
this talk and then.
So Cyrus, you have to stay a little longer. Cyrus thought he'd finish and go away.
Yeah. Well, okay. All right, got it.
Never mind. Suffer through my talk. Now I'm going to talk to you about the 10 top surgical video pearls which I've got. And I'm going to take you through them now, starting with the first. We'll start with cataracts, our bread and butter. We live for them. No surgeon likes to start his day facing a rock hard cataract. But let me show you some newer techniques to make your life not only simpler and easier, but also more enjoyable. This was one of the methods which I had developed over a period of time, which was essentially to convert a rock hard cataract into something which is easy to remove. Just imagine a donut. A donut has the center part poured out and the periphery is there. If you can do the same thing to your lens, irrespective of how hard a cataract is, life can become easy. So this is what I call as a locomotor, because simply like the pistons of a locomotor engine, you core out of the center of the lens. Let us see it in action. This is a nice hard brown lens. You look at it, makes your heart feel happy that you are a surgeon and you're going to enjoy it. And if you have to start your day with this type of enjoyment, the question is you'd like to think, और क्या कर सकते हैं, which is what I'm going to show you. Once you enter, it doesn't make a difference how you enter. I like utilizing diamond blades, not for any other reason excepting they give a cut which is really good. Now, with all these hard cataracts, you have to be very sure about your rexes. And I like to use the forceps, not for any other reason except that the forceps enables me to turn the rexes wherever I want it to go. Sometimes rexes have a mind of their own. Mood aata hai, they will give you a perfect round rexes. If the mood is not there, they will give you a rexes which is not round. But like a chapati, it tastes the same whether it is oval or it is round. Having said that, you hydrodissect it, lift the edge of the lens up, what I call as a lens salute, something which you have developed over a period of time. One of the advantages of doing this method is that you no longer have to worry about the posterior capsule because you have subluxated the lens forwards. Then you juggle it a little to make sure the adhesions go away. That's what the juggle is for. And now the whole secret is that you are going to core the middle of the lens out, leaving the rest of the lens intact. The whole secret is very simple. You expose your phaco tip a little more than normal. Normally we use the phaco tip, we don't go so much. But you expose it a little more because you want it to bury it in the core of the nucleus itself. And once you bury it in the core of the nucleus, you make your first initial opening, keeping your suction very low. Keep your ultrasound energy high, keep your suction low. When the core, it should penetrate into the middle of the core, cut it off, take it, turn it a little, and then make your next core. Depending on the density of the lens. If your lens is medium dense, 4 cores are enough. If it is not, if it is harder, you can take to 6 cores or even 8 cores. But just make simple cores. Don't try breaking anything. Don't do any gymnastics. Life is easier when it is simpler. Make your cores and then just, once you have cored out the middle of the lens, you're only left with the periphery. Then all you need to do is to anchor on one side and split it. And your lens will break into 2 parts. When it breaks, I want you to look in the middle of the break. You'll notice the cord area, which is the interesting thing to look at because it confirms that you have managed to remove the center. Look in the middle. There's nothing, virtually nothing there. It's only the edges of the lens which is left over. Once you're left with this, say, then doing the rest of removing the rest of the nucleus is chicken feed. So this is one of the easy ways in which you can handle a rock hard cataract without any difficulty. And the big advantage is that the ultrasound energy which you're utilizing is buried in the substance of the lens. So the next day your cornea is comparatively clear. If you were doing your energy from top and making grooving procedures, which a lot of people would like to do, then the energy tends to dissipate onto the inner surface of the cornea, the endothelium, which does not like phaco energy. So once you're done that, then the creases can be easily removed without any difficulty. So this is one of the techniques which really makes life very easy. Once you manage to break it into little fragments, then whatever the periphery can be broken into little chips and just gently removed. Let's go from here to something a little different. Another technique is to use something which I've started since the last 2 years or 3 years. is to use the Zeiss loop to cut the rock-hard cataract into itsy-bitsy sections. The loop is something we have used for many, many years. I started using a loop close to about 25, almost 30 years ago when we made a loop out of wire. We all used that. We used to insert it in. The big problem with that system was that essentially was that when you did that, usually the capsule broke and you were left with a mess. Now, utilizing the MyLoop, which is the Zeiss one, mind you, I have nothing to do with the MyLoop guys, the Zeiss paper. I'm first going to take it on a clear lens just to show you exactly how we work it out. 3 fundamental principles when you utilize the MyLoop. Those of you who haven't used it yet, please use it. It's a great device. Mind you, as I said, I have nothing to do with that Zeiss. Now, the important thing is, this is the MyLoop. You insert it in under the edge of the capsule and you rotate the loop. You can see the edge of the loop moving. If the cataract is not too dense, you will be able to see the loop and you can see the reflection because the cataract is too dense to get any reflection. But irrespective, it still works equally well. You can take it out and do it. So irrespective of whether you put loops or not, it works simple. Now let's get on to something else. Now let me show you the femtosecond technique where the cataract can be, as one would say, slide it into little bits. Here we have a cataract which we are going to be doing. Femto is a great way. People always turn around and ask me, what is the use of the femto? You can just as easily do a rhexis. Please remember that the femto gives you the advantage of a perfectly placed central rhexis. Why is that important? It's something which I've tried to stress over and over again. All capsules contract over a period of time. And when a capsule contracts, it sometimes contracts irregularly. When it contracts irregularly, if you put in a multifocal lens, you will find that the center of the lens is no longer in the middle of the pupil on the capsule, so that you don't drop it by mistake. So first thing is to use. We have capsular hooks. I don't like capsular hooks because they tend to stretch on the capsule and very often they slip out. While the regular hooks seem to work better. So I've gone back to using regular hooks. And once you can do that, then it's not difficult. We just hook all 4 of the pieces together. And having hooked it and taken it into place, I'm going to move a little faster so we can show you really what I want to show you in the end. Then you have to put in your ring to stabilize the capsular bag. Now, one of the ways there are various devices in which you can use. I like to use a Moller system in which the ring is fed inside and which is really a beautiful system to work in. Nowadays, we're getting preloaded hooks that works equally well. But just remember, do not select a hook in which the ring material is tight because it tends to occasionally break the capsule, which is not what you want. So you can easily do it. Once your ring is in place, it stabilizes. And then later on, of course, you can flip your lens into place. If you find at this point, this is the point at which where the area of subluxation is there, you like to put in a Rayner lens or a Rayner pattern lens so that it will also support the rhexis zone, the zone which is unsupported. And it will actually act almost like a support zone. One advantage of putting a lens of this nature, this is a multifocal, a lens of this nature is that in case you find it is still unstable, you just put your needles through the loops which are there and pull it out onto the sclera, and you can utilize the lens itself as a manner of supporting the capsule. Let's go on. And let's go on to something else now. Now, as they say, irrespective of how great a surgeon you are, once in a while you'll break a capsule. The only person who doesn't break the capsule is the one who doesn't operate. And all of us have unfortunately broken it at some time or the other. But let me show you how you can navigate it safely. Amar has shown his method. Long before Amar showed his method, I had shown this method also, which unfortunately never really did catch on. But it is something which you need to see because it is such a simple, fundamental method that once you see it, it becomes easy. I call it a HEMA lifeboat. Basically, it is a contact lens which is cut to a 9.5 millimeter size, utilizing a regular punch, autoclaved and kept ready for you. And all that you need to do, have no financial products, etc. I neither way have any. Now let us say, phaco usually calm, peaceful procedure, but if it is a rock hard cataract, once in a while you make a mistake and you get vitreous coming out. See, a strand of vitreous is coming out here. You try funny games and you know you're going to find the lens sitting at the bottom. At this stage, it's often you wonder now what to do. There are various ways of doing it. One way is you try and put a lens in and support it, but in a situation like I've showed you, there's no place to put a lens. So you take this lens, it's a pure HEMA lens, 9.5 diameter, you simply put in and punch it out, put it in a standard injector and inject it along the side of your what should I call it, anterior chamber. So you just have to put this lens in. 9.5 millimeter. Remember to use a +5 lens because it is more stable. The regular cartridge, which you utilize for your what should I call it? Regular injector, regular IOLs. This is a care group injector. Now, here what I'm doing is I've just made the lens fragments a little to one side, and here I'm just going to inject the contact lens in. See the lens going in? Injected anteriorly. Now you take the fragments and stack them like people onto the boat. Move the fragments onto the anterior surface. A 9.5 millimeter lens supports itself on the iris. It acts like a rock stable procedure. You can now do your phaco over it, and this is a hard brown cataract. So you can well see the fragments. You know that this, it tried any other way, this would have dropped inside. And there's no way you're going to escape it. But here you see the edge of your lens at the edge, with the 9.5 millimeter end sitting comfortably inwards. It will not go inside, it will not prolapse, nothing will happen. You can just remove your cataract peacefully, remove your fragments, and then at the end of it, when you're only left with cortex, hold the lens with a forceps and simply pull it out. It comes out easily, no hassles. But remember, 9.5 millimeter punch, a +5 diopter, regular contact lens. Any of the ones will work out. Acryfold, Acrysoft, any of the ones work out equally well. This is what it looks like when you take it out. And then, of course, you can proceed. In a short animation, just to bring it clear so you know the concept. A HEMA contact lens, all you need to do is you put it into your injector and inject it. When you put it in the injector, put it in a manner in which it folds over like legs. You do not do this, it will tear when it goes inside, which is what you don't want. So put it in, folding it over, and then fold it in, and simply inject it with viscoelastic. Number one. Number two, key point to remember, inject it along the side. Along the side. Take it on the anterior iris. Let it open and take your fragments and just put the fragments onto the surface of the lens, and then you can phaco it comparatively easily. No risk, no problem, no lafra. No question of having to do one, two, or the other. And the other big advantage is that your capsule remains intact. The capsule edges remain intact. Though you have broken the middle of the bag, the edges are still there. So later on, when you put the implant inside, you can probably put it on the anterior capsule itself, avoiding all the problem of suturing, fixing a lens. And at the end, you can utilize a hook and remove it, or as I showed it with a forceps, both ways around it works equally well. So this is the simple way, and really nothing to bother. Now let's go on to something else a little more interesting. Once in a while, you want to remove an implant. I'm going to show you two new toys. I'm going to show you two new toys which enable you to cut your implant and to peacefully manage comfortably. As I call it, I have nothing to do with both the companies. I had to buy the instrument. They didn't even give me free. So that's a different matter. Okay. So now you've got a lens inside and you wanted to remove the lens and replace it. We have done a peaceful cataract. We've implanted a lens and suddenly, once in a while, as errors will occur, someone at the back turns around and says it's a wrong implant. The patient had a multifocal, you put in a mono. So now we have to remove the lens. Normally, when this occurs, you always think, hey, yaar, lafda hone wala hai. This is made by Asico, which is one of the companies in the United States, which has a blade running in the middle. See the way the blade runs in the middle. So after you hold the lens, you only have to move the blade in the middle of the lens and it slices the lens into two parts. You don't have to cut it. You don't have to worry about the anterior chamber. You don't have to worry about the lens flopping around. So it's a nice little toy. When you go next time to USA, try and pick it up. It's really well worth it. So what you have to do is very simple. You hold the lens in the middle and cut it. I'll just show you how easy it is to use this device. Now this will work on all lenses excepting Acrisoft. The Acrisoft ones require a different cutter and I'm going to show you that also. So all you need to do is to just move one loop over the edge of your repositor. Keep your repositor there and just rotate your lens over. I've seen people struggling to move this over. Don't do that. Just put a repositor and rotate your lens over the repositor. It automatically gets your lens sitting onto the iris. Makes it easy. Now you take a little device which I just showed you, which is the Asico cutter, and you hold the lens in place. Support your lens a little and hold it in between. There's a little clamp which goes in between. You don't have to go all the way through. You have to cut it only roughly 3/4 way through. And move the cutter which slides in the middle of the lens. See, sliding in the middle of the lens, cuts it into two parts. Does not two parts, when cuts it through the middle. Cut it 3/4 is enough. Then you just take one edge of your loop and pull it out. One leg. That's all that's required. दो टांग की जरूरत नहीं है, एक बहुत है. And then you rotate it. When you rotate it, the lens, as one would say, rotates its way out of the chamber. So you really don't have to cut a lens all the way through. It's not required. Just rotate it out. But this is one of the easy few tips or key points which done. Now let us see. Now let me try and show you something else a little different again. Now what if we had put in an Acrisoft multifocal and you had to remove it? Then what would we have done? Then we utilize something a little different. An Acrisoft lens is one of the hardest to cut and remove. But let me show you a new toy. Now when you have to cut a tough object, you need two hinges. All the cutters have a single hinge, which makes it difficult. When you cut it, the lens rotates like this in a manner, flops against the endothelium, and the next day the patient comes with a long face saying, I can't see. Now this is a little instrument made by Rumex, which has got a double cutter hinge, which increases the power. All you need to do is simply visco, and so you have the lens, you rotate it out as I showed you earlier, put in your repositor, rotate the lens out, and then you insert your cutter and move it inwards. All the Acrisoft loops will rotate out easily enough. That's not a problem. Just hydrodissect below it. That is the key, not on top of it. Pushing on top doesn't work. You have to push it from below upwards, which it does. And having done that, the next step, of course, is simple. You utilize a little new cutter, which I've shown you, made by Rumex, which goes in. And you will notice there'll be no flexion of the lens when it's inside, and bury it. I call it sclerocorneal transiridial, secondarily sutured IOL. Now the whole secret with this method is, and let a short animation to explain how this procedure works. But essentially what we have to do is suture your lens inside. So it goes in through a cut in the sclera, 3/4 depth, so that essentially the sutures get buried into the substance of it. That's the whole secret behind the procedure, but the lens essentially should lie and stabilize in this manner. Let's go on and see how it works. Once what do you need to do? You first need to simply dissect the conjunctiva a little off. Just follow the steps. They are very interesting. Yeah. And then apply a little cautery, get rid of the excess bleeding. It doesn't look nice. Then the next step is, in case you have a diamond cutter, if you have a cutter which gives you a groove of 0.5, this is a Mesco cutter. We normally set it at 0.4 or 0.5, and we make a horizontal groove at the sclerocorneal junction. Vertical corneal groove. At 0.5, it will not penetrate through it. At this zone, you require a 0.7 to penetrate. So it's only as one would say, halfway thickness inside. Then you take your needle and you go with the swagged 10-0, go through the iris, and from the other end, use a needle and simply take it out through the needle again, what we're calling a tramline or railroad. I never understood why they call it a railroad, but still. Either way, the needle goes all the way through, and you got your suture which is lying in between. Now the next step which you do is again very simple. Pull out your needle and take your hold the 10-0 monofilament proline, pull it out and suture it to both ends. Now that is simple and straightforward. We are not too bothered about it. What interesting comes is, once you put your lens inside, now how do you proceed? Because always the problem has been that you got two sutures hanging outside. They sometimes poke, they sometimes cut. Or to do that, or to bury them, you have to make a flap, which is again a nuisance. And you have to seal the flap on top, or you have to glue the flap. Here you need to do nothing of the type. Just simply put it in. Let your implant go inside. And once the implant goes in and sits inside, then you just pull your edges of the suture on both sides out. The interesting part is down. That is where the trick of the whole procedure lies. That's where the fun lies. As they say, there's the rub. Bury your suture into the depth of the cut that you have made and pull it out. And then simply tie your suture at that point there. So the one side loop which is there, which you already used to get out, and the loop which you have created by putting the needle through the substance. Now, when you do it in this manner, the knot which is formed gets buried into the substance of the cut which you have made. You can juggle it a little. See it once again. Take your needle and go through the base and take it out again. You have to go through the base of the cut which you have done. And then just use the two loops. One loop which has come from the tie which you have done onto the lens, and the other one cuts outside, and you cut it and bury it. This buries the suture into the groove. So there is nothing then left to see. It will never trouble you and will remain fine. That's all you have to do to get it done. And this is what we call as trans-iridial suturing. Makes life easy, makes life simple. And it's a good technique which you should consider once in a while. You get bored doing all the other things all the time. Kabhi glue kiya, kabhi nahi kiya. Here, no glue, no nothing. Just pull the conjunctiva up a little and leave it at that. And you're fine the next day. Let's go on to something else now. I'm going to use The other method is what we call as the new technique is what we call as the proline-based Kawabara suturing technique. But in that also there are a few tricks which make life easy, what I call as pointers. The Kawabara technique is great, done with the proline. It's been about now 3 years or 2.5 years old technique. This is the Yamane modification of the Kanaprava method, which is one step ahead, on which yours affectionately has added his own modifications. So it is meta modification or Yamana modification of Kawabara. Now, as you notice here, everything is loose. The bag, lens, everything is loose. And you can talk of suturing it, but you try suturing it and everything is going to drop inside. So the line of treatment for this sort of a complicated case is again very simple. Make a small conjunctival opening and remove it on both sides, because that is where I'm going to put in the proline and hold it in place. A little cautery to control the bleeding. Oh, whatever. A little forward. Yeah, that's right. Okay. And once you've done that, then the next step, which we already did, do it again. More forward, more forward. Then you simply mark 3 millimeters on both sides of the sclera, utilizing a standard squint hook with a little bit of dye attached to the tip. You followed? Just make these marks. I'll explain as we go along what the marks mean. And always utilize an AC maintainer. Now your needle, you prepare the Yamane tunnel by just using a regular needle and going horizontally through those marks which you have done. So you got 2 little tunnels which have been made. You have not yet entered the chamber. Here I'm removing now the lens, and as you'll notice, immediately after the lens comes out, the bag comes out with it, indicating that had I tried playing any games with it, it would have been sitting, bag, lens, everything would be sitting inside. Only disadvantage of the HF maintainer is once in a while you'll find things tending to come out, but nothing. Insert an air bubble which tells you that everything is sitting, and most important thing of all, close your incision before you move forward. That is a key thing to remember, because if you do that, then life is always easy. If you don't, you'll start getting vitreous oozing from there, which makes life very difficult. And then you utilize a standard proline suture needle which we utilize, which is a 5/0 cutting needle, and thread it into a 27 gauge needle. Okay? Just do this method. Proline, you thread it into a 27 gauge needle. Now you remember we made that horizontal opening. Now you go through that opening but turn your needle onto a right angle and go inside and just pull out the proline. Same way, go through the little tunnel which you have made, turn it at right angles and remove it. Why did I make this tunnel? Because sometimes when you do these proline loop systems, it sticks. Now, how do you handle it onto a lens? You put your lens onto a rubber bung. Actually, this is the bung which you utilize for on your operating microscope at the sites. And you simply make a needle opening through the base, roughly at the base. And the same suturing which you have done, the suture which you have pulled out is now threaded back through that second needle which you have placed in. Once you have done that, then you move the lens onto it. So your lens now lies freely floating. At this point, it is very simple. You anchor your lens onto the proline by utilizing a thermal cautery. This is a low temperature cautery. These are actually available on Amazon. And it's quite different to the regular cautery which tends to break. Make sure you pull it a little to make sure that it doesn't slip out. Put your lens in, and then you can center your lens easily enough. Just be sure not to cross your sutures. That is the important thing to remember. Apply a little traction on both sides to stabilize the lens. And then remember what I told you. Close your incision. People always try to handle the proline part first. Don't do that. Don't leave chambers open. Two things tend to happen. Sometimes the pressure changes and you tend to have a problem with the retrobulbar hemorrhage. And number two, the second alternative is that you get vitreous pouring out. So now you apply a little cautery on both sides, but leave enough at the end so you can still have enough place to adjust it. Now a little AC wash, anterior vitrectomy with steroid, which is compulsory to make sure you don't have vitreous lying in the center. This is the Alcon cutter which we're utilizing here. Make sure it is all clear and done with. And then at this point, you can now adjust on both sides. And you can coapt the conjunctiva over the edge utilizing a coaptation faucet. So you don't have to suture, you don't have to do anything. So this is the way you can get away with this also. Now let's go on a little. Sometimes we are stuck with patients. Finally, I'm going to show you the last one, where despite having done a trap, the IOP refuses to come down. I'm going to show you a little valve which I developed a few years ago. It's a little toy, straightforward. I'm actually fond of it. And essentially, it is a valve which is what I call as a below surface. See the little knobs on the valve. It's a silicone valve. And the advantage of the valve essentially is that the conjunctiva is held up, so it doesn't cause any problems. And as we do with all the armored valves, this is a type of armored valve. All you have to do is you utilize a 5-0 suture and you anchor the valve onto the surface. And this is now what I want to show you after having sutured it, is how you make the stirrups to put it through. What you need to do is very simple. You make two vertical cuts utilizing a diamond knife. A diamond knife which is set at, normally we set it at 30 microns, and make two horizontal cuts. It literally forms stirrups. Stirrups are the things we attach a saddle on a horse. So rather than doing and dissecting it, you make those two stirrups, then you utilize a diamond knife to clear this place in between. Then subsequently, all you need to do is to cut it, giving you enough place. You can always cut it a little longer, never shorter, because in case you need to readjust it later on, you can adjust it. And you put it through the stirrups, which you have made, and introduce it inside. Advantage of using stirrups in this manner is that there's nothing to be cut, nothing to be stitched. It supports itself, and because you've gone through scleral thickness of 0.3, you're never going to have a melt on the surface of it, which is so often tends to occur with this. So this is an easy way in case you're doing an armored valve. I'd like to thank you for your attention. I hope you like the tips and the techniques which I've offered for your perusal. But I find these a little interesting, and I thought they'd be fun to do next time when you're doing your surgery and you're wondering, kya yaar bok rahe hain? Now we are Thank you so much, and thank you, Vardhaman, for the opportunity of
Thank you.
some of my toys.
Yes, thank you, sir.
Thank you, Kiki. Thank you.
So innovative, and I think we have all learned so much. Each and every case, each and every video, each and every surgery has given us so many pearls. So thank you again, sir, for this amazing presentation about your surgical and clinical pearls. I would like to now invite Dr. Atul Kadane, our Honorary Secretary, to introduce our panel, who has been distinguished and very closely associated with Sir for a very long span. Over to you, Dr. Atulji.
Yeah, thank you, Vardhaman. Good evening, all. Good evening, sir. This concept must have reminded you of our Guru Shishya Parampara. And the sir had really do a hand holding with us with his tremendous experience and knowledge and learnings. Today we have as a panelist with us is Dr. Ranjit Maniar sir, then Dr. Kirit Modi sir. We have Cyrus with us, and um, Dr. Prakash Kankriya sir as a panelist. They have a lot of they spend a lot of time with the sir, so they are to be a panelist. They are to be in a very ideal position. So I think let's have the discussion move forwards. Thank you.
Thank you, Dr. Atulji. I think so. I think we will start with the senior most of our luminary panelists, Dr. Kirit Modi sir. Uh, Dr. Modi sir, uh, can you please on your video and or your audio, please? Aditi, can you please connect with sir once? Right, just a second. So till the time I think sir comes on board, we would like to go and speak to Dr. Ranjit Maniar sir. We all know that Dr. Ranjit Maniar sir has been so closely associated with Professor Mehta sir for such a long time, and of course, I have always seen them together organizing the I-Advanced meetings, and also we have learned a lot. The way we have learned a lot from Dr. Mehta sir, we have also learned a lot from Dr. Maniar sir. And apart from ophthalmology, of course, his knowledge of constitution and AIOS and MOS, the way the society should function, we have always learned about it. So over to you, Dr. Maniar sir, about your experience that you have shared with Dr. Mehta sir.
Thank you. Thank you, Vardhman. It's an honor. And frankly, it's a pleasure to talk about Keki sir. Always. Keki sir just doesn't teach in the conventional way. That you've seen in the videos how he can go and teach you with the video, he can teach you in his OT, that is there. But there are subtle things that you have to pick up on your own from him, not only in his surgical skill and technique, but also from his persona, from the man itself. And I'm going to run you through a few of the gems that I have been fortunate to encounter. I'm going to take you back to about 1976 or 77 when we had the first Maharashtra Ophthalmic Conference, which was not in Maharashtra, it was in Goa. And Keki sir was the keynote speaker there. And I learned such a lot on public speaking because for the first time, I saw somebody come down from the stage into the audience and he started interacting with people in the audience from the aisles also. And for me, it was a cultural shock. How can a speaker come down from the stage and move along with the audience? That was one. Incidentally, even in those days, he was a pioneer speaker because in those days he was talking of something which was totally different, and that was contact lenses, something which was very new at that time, contact lenses. And the HEMA part came later, but the 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 just that contact lenses in India in 77, 76, 77 was something which was very, very new. That was about public speaking from Sir. And then our association grew, and Sir roped me in for the I-Advanced conferences. I'll tell you one thing: trust. He put your trust in you. He delegated work, and he never interfered after that. Never. Ranjit, this has to be done. It has to be done. Fortunately for him and for me, I got it done. But the point is that when he delegated, he believed in you, he had your back, and he trusted you totally, completely. On the surgical side, I'll tell you, we were at Chitrakoot in about, I think it was around 1995 or so. And Sir was teaching me phaco. And he taught me his innovative technique And he gave me one secret on the phaco and he said, look down. I looked down at the foot switch. He said, that is your key to phaco. The foot switch and the control on the foot switch is the key to phaco. Your hands will assist your feet, but your control is on your foot. Then he tells me, now you do the next case. So I said, sir, I've just learned from you. You do the next case. I'm here with you. I start the case and then he tells me, you know, na, you're live. Huh? There are about 40 to 50 people watching you. I said, sir, he said, don't worry. I've got your back. I've got your back. I am there. You don't worry. You can operate. You can do this. And that is the other thing about Keki is he always has your back. Always. Stand with you, by you, support you. Any situation in life, whether it is surgery or even non-surgical things. I don't know, Vardman, how many of you have watched Dr. Keki make a glaucoma flap? A flap. You make a flap which is something rectangular, etc., with this size and this size and this. No, not Keki, sir. The way he makes a glaucoma flap, there is always a better way with Keki, sir. Always a better way. He is just not satisfied doing things the standard way. There is always a better way with him. And I think a little bit of that, little bit, has rubbed in into Cyrus also. Cyrus, I'm talking about you. So that is the thing is that he is like the SA node in the heart, you know. It's never silent, it's forever throbbing, forever innovating, and forever just not satisfied with what it is doing. There's always a better way. Did you watch the first or second video on phaco today, what Sir showed? Did you notice that the conjunctiva was not touched? Conjunctiva is not touched, that is a minimum tissue handling. And the next day, he is able to ask the patient with a clear conscience, which eye did I operate?
Correct.
Because both eyes are quiet. Because you've not touched the conjunctiva. That is a fundamental mistake we all make is we put a forceps and we hold the conjunctiva. Sir never does. He has a bud. He has something else to support, but he's not going to pinch the conjunctiva. Which eye did I operate is the key. There was an incident in Calcutta, I think. We were operating live and Sir was doing an experimental surgery with a new type of a handpiece, which was a water jet technique. Sir, bolo na.
बराबर છે, बराबर છે.
So this now normally Keki sir, when he operates, it's about 2, 3, 4 minutes and the case is over. And when he was demonstrating live this water jet technique to cut down the nucleus and to then suck it out, what happened is that he went on and on and on and he kept on talking and talking and talking and he went on and on. Ultimately, the case got over and we came out. I was in the OT with him and I said, Sir, Suthu, what happened? Why so long? And quietly he tells me the damn thing didn't work here. The handpiece didn't work. Now, imagine there is over 1,000 people watching you live in Calcutta. The handpiece doesn't work. Keki doesn't say, change the handpiece, give me a conventional one. I'm going to switch over. No. He's got the back of the sponsor also. He completes the surgery with a semi-functioning Aqualase and still manages to have 6/6 the next day. Innovation. You saw his instrument handling, the diamond knives that he uses. That is so that you get a minimum astigmatism, the best wound possible, and the best instrument.
No, actually, that is because only metal things are only used to eat food. Diamonds are used to make incision. Remember that famous line? Yeah. Forks and knives on the dining table are made of metal, but incisions are to be made with diamond knives.
Absolutely,
That's true.
absolutely.
That's true.
And it's cheaper to have a diamond knife than to have a disposable blade. You say, "Okay, okay, this disposable blade is only 38 rupees or 50 rupees or whatever." But a diamond knife is virtually something that gives you a completely reproducible surgical outcome. Reproducible each time, every time. Now, what do I tell you about his humility? We've all been there with him. Humble to the core, yeah. Innovative, absolutely. Even,
That's true.
I won't say at this age, but even now, absolutely looking for a better way to do things. A surgeon par excellence, a mentor par excellence, most important, a friend par excellence. He's always taught for free. Huh? Anybody is welcome to his OT, to his clinic, and to sit with him across the table, even he'll give you dinner also. And you can pick his brains at any time of the day or night, and it's there, it's done gratis. There's never this thing. There's only one thing that I have not picked up, or I'm on the way to picking up from Keki sir, and that is he's told me many times, Ranjit, if it's curved, the pant will slide down. Use suspenders. Use suspender. And this is possibly the only thing that I've still not picked up from him, because I'm on the way to have a fairly corpulent belly, and suspender, it is going to be something that I will also incorporate soon. Thank you, Vardhan.
Thank
Sir, it's been an honor and a pleasure.
Thank you so much, Ranjit. Kind. You
thank
didn't tell them about the time I kicked the bathroom door down, so it's okay.
Thank you, sir. Thank you so much. And I think it was very heartfelt. And of course, we have uh, indirectly learned a lot about sir from about KK Mehta sir from Dr. Maniyar sir. Thank you so much for that. And we'll go on to speak to Dr. Kirit Modi sir. Sir, are you online now?
Yes, I'm on the line.
Yes. Thank you, sir. Sir,
Can
can
you
you?
hear me?
Yeah. Can
Yeah.
you? Yeah. If you can start your video.
Yes,
Yes,
yes.
please.
I come across a number of ophthalmologists. Some of them excellent surgeons, some of them an astute clinician, while others a good research worker. But here is a combination of all the three. Keki sir is a Shiva, has got all the gods in it. Is an excellent clinician, I think one of the best surgeons, and with a research mind. So every step he does in surgery, it looks how we can improve. And that is why on the top of it, he's a good speaker and had a tremendous organization capacity. He's been running iAdvance for the last 20 years, single-handed.
Nine. It's with Ranjit and you.
Apart from that, he's a very good human being. He's my friend for the last 46 years. We started meeting first time a contact lens conference in 1947. I today enjoy tremendously his Pima lens technique for taking it into a lens pieces in a capture, posterior capture. Also enjoy some of his scleral fixation lenses. It's an excellent video we are showing today. I pray to God, long life, healthy life, and stay with him.
Thank you so much, sir.
Thank you.
Thank you, Kirit bhai. Thank you.
Yes. So thank you, sir, especially being present for today. And sir is the senior most, as Dr. Keki sir said. Sir is Kirit Modi sir is even senior to Dr. Mehta sir. I think we are very honored sir, to have you. And from the bottom of our heart, from Team MOS, thank you so much for being present today.
Thank you.
Thank you, sir. So now we will go on to one and only Cyrus, Dr. Cyrus Mehta. Of course, he himself has achieved so much of recognition, both internationally and nationally himself. And being a son of the legend himself is not a, let's say, it's a very tough job. And I'm very happy and proud to see that Cyrus has been doing wonders and has created such a niche for himself in international and national arena. So over to you, Cyrus.
Both Vardhman and Cyrus are aware of the fact of very large boots to fill.
Yeah.
Thanks very much for having me, guys. Well, I think they've actually said everything. So the reason I didn't, I was not there to see his 10 tips because I've been seeing it since last 25 years.
Yeah.
So, and that trip to Chitrakoot, I think I was also there. And I also learned FECO in Chitrakoot only. And I think it was 2000. It was 2000. Vardhaman, how old were you in 2000?
2000, I was 18-year-old.
Yeah. I was trying to learn FECO in Chitrakoot over the course of 1 week. He said, see, you have 1 week to learn. If you can't learn in 1 week, then, you should try something else. Because even a donkey can learn surgery in 1 week. I said, now, well, that's really that's not a really very long time because other people had 2 years FECO fellowship. So I used to wonder actually what they did for 2 years. So I went to see what other people were doing in FECO fellowship for 2 years. So for 1 year and 10 months, they were doing SICS, and last 2 months they were doing. I said, okay, then it can't be that hard. I can do it for 1 week. So that was my first introduction. Before that, of course, I didn't hang around with him. I didn't know much about him. He was a great guy, and he was the most famous ophthalmologist in the country. Today, there are so many famous ophthalmologists. And when you go abroad, there's this one and that one and all. In those days, no one was there. So when you went abroad with dad in, say, 95, 96, I went to the American Academy in 96. That was my first meeting. At that time, you were 14 years old. And so I remember that everybody knew him. He knew everyone. Because there was no other ophthalmologist from India actually attending or presenting anything at these meetings. And you couldn't learn a surgery on YouTube. So today, anybody with half 195 IQ also can watch the surgery on YouTube, buy the machine. And eventually, everyone learns how to do it just the same way that we learned. But, it takes a lot of guts to learn a new surgery like FECO on your private patients without having a government hospital to go and practice on the patients or doing it in a fellowship when somebody else has to bear the brunt of bad surgery the next day. So learning surgery on your private patients is very, very hard. And that's what dad has done. And I think that's the most difficult thing, is to learn a new surgery and learn... can you hear me? The internet connection okay?
Yeah.
Learn new surgeries. So dad has learned, he started with ICC, then he learned ECC. I remember the ECC days where a house was full of PMMA IOLs stacked from bottom to top because he was doing 20 surgeries a day. Then came the FECO days. I remember the FECO machine came when I was in 10th standard, about 1987. And the first Leica microscope came. And the YAG laser came in 1987. And the clinic was part of our house. So now half the house disappeared because there was no place to keep the YAG laser. So one room became YAG laser room. And so I used to play with the YAG and shoot holes in carbon paper. That was time pass. And then the first FECO machine came, which was about this big, huge, big thing. And he was doing FECO every day. So he was never in the best mood, when he used to come home. Because I don't think learning FECO by yourself with no YouTube video, no text, there was no textbook written about it. So you couldn't read a book and learn because no one was writing anything about anything then. And there was no online access. There was no journal. There was no ESCRS. There was no ASCRS. So there was no one to learn from. So you had to either figure it out yourself, otherwise not do it. Then from FECO, Catalyst came. He learned that also. He learned Smile. He learned LASIK. So all these procedures have come, we learn a lot of these things before we start practicing. But I think everything we do today is learned along the way. And that's really hard, yeah. And I think he's just going to keep working. There's no retirement age for him as such. And that's great. So, there's the sky is the limit. He'll just, if something new comes, he's going to do that as well. So
Absolutely.
it is hard being the son of a famous man because it's very difficult actually in private practice because nobody wants to go to you first of all, and nobody in his right mind will go to you. Even I would not have gone to myself 15 years back. I would have gone to him only. So, that's how it is. But you learn with time, just as Vardhaman has learned, and you have to kind of make your own way. Yeah. And this is what Dr. Manyar told me. This was 1998 in Chitrakoot, where I went to learn ECC. He said that you have 5 days to learn ECC. If you can't learn it in 5 days, you're never going to learn it. Then don't bother. So he said, see, Cyrus, I see you struggling to learn and all. But remember, there's only going to be one Keki Mehta. But you are Cyrus Mehta and you are also a jolly good fellow. So you be happy with that. So I said, well, that's also not bad advice. Yeah.
Not really.
And do you have anything to say?
Not really true about that. Cyrus was one who learned very fast.
Yeah, because I had only 5 days to learn. After that, I'm not teaching you. So whatever you want to learn, you learn in 5 days. After that, you do by yourself.
Let me tell you something. Cyrus just operated me a month ago.
Yeah.
I have now trifocals in both my eyes. And, just aside, a talk aside, I was looking forward to finding the rings which everybody spoke about. I put in a trifocal which is made by Alcon.
Panoptics Clarion.
Panoptic Clarion. And the first day when I got out, a moment I was operating in front of the table is a clock. And I could see the clock and I could see the time on it. So I said, hey, yaar,
Beautiful.
able to see. And it recovered pretty fast. But the interesting thing is, I still haven't found the rings yet. They keep telling me that you will see big rings in the street.
That's because your pupil doesn't dilate much. You asked me, na? I did the surgery.
Whatever it is, rings are not there. They talked of glare. I look at the street light. Okay, around the light there's a little glare which is there, and really it doesn't bother me. And I can't figure out why people jump up and down. I have trifocals in both eyes, and the beauty about the whole affair is that you get up in the morning, you don't have to find your glasses. You can suddenly see. You can see the bedside watch. It makes a world of difference.
Absolutely.
So who decided the lens?
Me.
You ultimately have to leave it to the surgeon.
Operating surgeon's choice.
Kudos, Cyrus. Yes,
Yeah,
superb.
very nice.
And thank you for sharing with all of
So
us.
any problem in your operation, sir?
None whatsoever.
Through
I don't think so.
operating microscope.
I started operating on the 4th day.
Wow.
To get a little easy thinking, सारा infection नहीं होना चाहिए. You're going to sit in a clinic the whole day, लफड़ा हो जाता है. But the 4th day, I had a list. I think I had a list about 10 or 12 cases, and I forgot about the fact that I had been operated. It just
Wonderful.
works. It works very well.
Good, very good.
Under high magnification, I don't think even the slight blur which was there for the first few days really bothered at all.
See, now you all know who to go to when you all get cataracts.
Yeah, that's why I'm asking.
Yeah.
Cyrus will be
You're going to be flooded with ophthalmologists now.
Yeah, well.
That's good, yaar. बाप से बेटा सवई.
Well, we try at least. Yeah.
Vardhaman,
Dr.
we have to
Manyar
move
said,
fast.
that you can't be
We have to
Keki Mehta,
move
but
fast
at least you
little
can be
bit.
Cyrus Mehta, and that's still good enough. Yeah.
That is, you're getting, I think
fact,
you're
I was
operating
the
on
one
Professor
who-
K.K. Mehta. What more you can ask for? Yes, superb.
Yeah, I agree.
I was the one who goaded Cyrus to start practice independently elsewhere.
correct.
Yeah.
Minute he sat at Metta International Eye, he was just an observer. He used to watch patients go by his room, into the last room, into Sir's room, and they just kept moving. And he was twiddling his thumbs. So I said, Cyrus,
That was very good learning time. 4-5 years, I sat in the room and no one came to me. But then, in the OT, I operated them all because once they're draped, they don't know who's operating them. It was a good place to learn. It was a good place to learn for sure. And it makes a huge difference. Otherwise, when you start your practice and you have first 10 cases the first year and 20 cases the second year, it will take you a long time to learn. Here, I joined a practice which was doing 2,500 cataracts a year. So I could do 500 a year easily, and quietly and
Perfect.
learn everything. So
Amazing.
that makes a huge difference. And otherwise, I wouldn't have reached here this quick.
Yeah, now we know why I trained you so well. I had to look after myself.
Yeah.
Amazing.
Vardhaman.
Thank you, Cyrus. And now, lastly, we'll go to Dr. Prakash Kankriya, sir, and he's going to share his experiences with about Professor Mehta, sir. Yes.
That's great, yeah. Like I really enjoyed this evening. After Diwali, this was a really good Diwali. I really enjoyed. Keki, you are my one of the best friends like I had in my life, and you were one of the best guide in my life. Like when I came into practice or when I started joining conferences, you were the idol. Like we were looking for, and you were looking at us like younger brother always. Like I appreciated when we were in implant society that time, and I was very junior, but you were keeping your arms and around me, and like we were talking, and I was like from a very small place, and I appreciate that. Like you were such a big personality, but you were such a big human, and after some probably 1 or 2 years, like we all sat together and we started talking about a different refractive society of India. And I was shocked, like you and Babu. Like I was very junior, and you appreciated and you promoted me as founder president that time. And hats off to you. Like you are really of great heart. And say after 2 years, like we saw like that time only RK and ALK were the development in refractive society. And then we again sat together, and in Chandigarh conference, we decided that the refractive society would merge into the implant society. And now today we have that name, like Implant and Refractive Society. But as a great human, and of course a great humor also, you had that art of humor also. You make everybody like at very ease, and I like even in like different international conferences. It's like whenever I meet somebody, people always remember you. Like they always give your reference to us, and we are really proud that we are from Maharashtra, and we are really proud that one Maharashtrian is doing such a wonderful job in this ophthalmology. Hats off to you. And Cyrus, you are so fortunate to have such a wonderful father, and you are doing excellent. What I said, "Vapse beta savai," is true. Like, and every father is proud that his son is doing so like excellent lifestyle in his life. So congratulations to both of you, like Keki and Cyrus, and like MOS, to have a great opening batsman here today, like Keki, and really like it has created that atmosphere. Okay, अगली बार कौन आएगा, अगली बार कौन आएगा? Say that has to be like that. It was wonderfully organized. All MOS team also, congratulations. And Happy New Year also. Like we have just finished Diwali, but today was wonderful crackers we had in this meeting, and wish you Happy New Year also. Thank you.
Thank you, sir. Thank you so much.
Thank you very much.
All Vardhaman's efforts and
No,
MOS's.
thank you, all Team MOS, led by our President Dr. Agarwal, sir, and the whole team has supported so much. And now I think we will go on to basically the video of Professor Mehta, sir, who is going to show a short video about his day, the day in the life of Professor Mehta, sir. So we are all looking forward.
It is really a short video because my day is very simple. I do the morning and just see patients in the evening here. You know, one of the reasons I have not retired is simply that people ask me that when are you retiring, and I turn around and tell them that if I retire, what will I do? I'll sit in a drawing room and wait for people to come and visit me. But here, I'm sitting in a room, they are visiting me and they're paying me for the privilege. How much better can it be?
Perfect, perfect.
That is the end of the retirement concept.
The video I'm not able to see somehow.
Video nahi aa raha hai?
I can see your screen where the list is there. I don't know about
Yeah,
others.
the video has not come.
Maybe you can open the video
One second.
and then go to sharing. I think that may work
Yeah.
better. Now we can see it. Yeah.
Can you all hear me? Can you all hear me?
Yes, yes.
Yes, yes, sir. Yes.
I'm going to try and show you something which is an additional important tip.
Yeah, yes, sir.
Betadine solution has a normal betadine solution has a pH which is comparatively quite acidic.
Right.
And the whole idea is that before you proceed, you should neutralize that acidity. The pH is of 6.2. You have to bring it down to 7.4. So we always add soda bicarb solution onto it. And you have a little device which I'll show you in a few moments, which is essentially nothing much more than a pH meter. When a pH meter, you should know exactly your pH. Why is this important? The reason why it is important is this is the sodium hydrogen carbonate we added. The reason why it is important because some of the cases which I had cancelled, the next day the eyes, the corneas were still affected. And I kept wondering as to why, when you have not even touched the patient and only washed him, as it caused. And then we realized that the problem occurred because we were using a solution which is the wrong pH to wash the eye. And betadine breaks down the surface epithelium bonds, and it tends to affect the cornea. So remember, in all your cases, to use this sodium hydrogen carbonate, which is freely available, to neutralize it, and use a pH meter. Let me show you that meter. And you mix it. This is the little device which is there. It doesn't cost you anything. It costs about 3 or 4 thousand rupees. It's known as a pH meter. You just soak it inside, and you can then control the pH of the solution to use. But I do feel that whenever you prepare betadine, this is something which you should utilize as a regular routine because it saves the cornea a lot. Very often, the next day cornea, when it's a little misty and a little hazy, it's your betadine which is causing it and not your surgical problem.
Great. Great tips, sir. Thank you.
In my case, then after I won't go into any more surgical problems, but just to mention that after that I run an OPD. Basically, I operate in the morning from 8 to about 2, and then from 2:30 or 3 I sit in the OPD till about 9 o'clock at night. Or
Wow.
if it is not good, then 10 o'clock.
That's a long day, sir. Yeah.
It's a nice, comfortable day. यार अब आराम से बैठा हूँ, काम तो कर नहीं रहा हूँ. I mean, it's a question of enjoyment. And I do cataracts on Monday, Wednesday, Friday, and I do LASIK and Smile on Tuesday, Thursday, Saturday. And that is usually the end of the whole affair. So that essentially is my life. I really enjoy. The night, I do what I've always done. I make sure I at least read ophthalmology for an hour and a half before I sleep at night. Because I found that if you don't do that, it will pass you by. And then later on, little kids will then ask you questions which you won't know what you're talking about. So then reading at night is compulsory, irrespective of what you do in the daytime. You can go for a drink party, have 5 drinks, but you'll still come back and read that 1.5 hours at night. I think that really makes the difference in the long run.
That's very inspiring, sir. Absolutely.
Very inspiring. Yeah. Or ophthalmology or beyond ophthalmology, sir? Both.
You see, the thing is, I read everything which I can find. I mean, I'm also very interested in science fiction, so I read science fiction books also. But ophthalmology is the compulsory read which you need to do because you have to keep yourself. I realized at a particular time, maybe about 8 or 10 years ago, for some period of time, I said I was working the whole day, and I started slacking off. And that was the time when electron microscopy came. And we went to a conference and people were speaking about electron microscopy techniques. And I didn't know what the blazes they were talking about. And I felt quite sad with myself that I have reached this level. So from that day onwards, I've been careful always to maintain my level of knowledge to at least to the power at which when people speak, I should know what they're talking about.
Amazing.
Yeah, so I think this is really inspiring for everybody.
Absolutely.
We should read daily.
Rather than spending time on Facebook and Insta.
Absolutely.
Yeah.
Sir, one question I have.
Sure.
How to become a good surgeon?
How to
because so many people operating, but still how to become how to acquire the good surgical skills? What are your tips to the novice surgeon?
I'll explain to you that. That is also something a little interesting. After a certain period of time, this is when Cyrus was already coming along with me. And we used to go to the international conferences and I used to go and watch some of the videos of surgical videos. And Cyrus used to ask me, that why are you watching these videos? You mean you're already a surgeon by your own right. You don't need to watch all this stuff. And I used to tell him that every surgeon has a certain point and a technique by which he does. And one of the ways in which you become better is to study what they do. So I make it a point, whenever I go and visit anybody, to see him operating, because you see a totally different way of handling it. I agree there are that a cataract is a cataract is a cataract, but no two people handle it identically. And it's these little things, little tricks which really make a difference in the long run. When Mr. Houdini was a great musician, it's only that he learned a few more tricks than the average person did. So if you want to be a Houdini in surgery, learn from everyone, irrespective of how good you think you are. You never are good enough not to learn.
Santosh, as Cyrus said, you have 5 days. Spend them in Mumbai with Keki sir.
Yeah, definitely. That will change your life, sir. Definitely.
Absolutely. I think we will also ask Dr. Mandar sir is there with us.
Mandar sir is there.
And if you would like to ask any questions to Dr. K.K. Mehta sir.
Yeah, thank you very much. A lot has been said about Professor Dr. K.K. Mehta sir. And I would only draw one parallel with one more legend we all look up to, Sachin Tendulkar. This is a story which resonates with what Sir said, that you may be the legend, but you need to practice every day. And I think what Sir said about reading, that one thought or that one idea or that one thing which he does in his day is, I think, the key to his success. Because he's someone like Sachin Tendulkar. He may have scored 100 hundreds, but even then he went out and did his net practice because he knew that it just takes that one ball to get you out. So he wants to be perfect. So this is exactly what Sir is. And I think that is why they are legends, because they keep their eyes on, below their feet, and they know the ground that they're walking on. And hats off to you, sir, for the immense contribution to the world of ophthalmology. And just to share a small story, I remember when I was doing my residency in Pune way back in 1994, I saw the first phaco surgery done by you in one of the conferences in Pune in 1994. And it was amazing. It was really amazing. And you made it seem so simple when people around, sitting around in the hall, were really scared of touching a phaco probe. But I think it is we must salute your determination, the way you plan things, and even the fact that you do the same even at this stage in your career. So thank you for sharing the pearls of wisdom, and it is a great inspiration to listen to you and interact with you always. Thank you.
Thank you, sir.
Mandar, what I think, he more resembled to Amitabh rather than Sachin because he is not retired yet.
That is also true.
I was thinking that
Sachin got retired, but sir is still working.
Yeah, sir, not retired.
and how the duration of Sachin was much, much, much less. So, yeah, Keki is, I think Amitabh is the Keki of Bollywood.
Yes.
Yeah.
Amitabh is
Aditi,
Right parallel.
Aditi, you want to share something?
You want to ask anything to sir?
Can I
Aditi?
ask his?
I think Sir has that like he's truly a legend, and even for a non-cataract surgeon like me, it seems so interesting and tempting to start cataract again. So it was really nice, very nice.
Aren't you retina? You're a retina.
He's the
person.
oculoplastic.
Ophthalmoplasty surgeon.
Sorry, sir. Yeah.
Sir, one question I have for you, because now you have done right from, of course, the entire gamut of cataracts, right from ICC till now current generation Centurions and Catalysts, and you have seen the entire gamut of also lenses. So when you started to implant your lenses in 1980s, and now what is like for those patients who are still under your follow-up, what is the current conditions of those lenses, and what do you feel has been, let's say, apart from the multifocal or trifocal designs, what has been the improvement in the quality of the material over time? Is what is your opinion about?
The funny thing is, PMMA has been the strong point of intraocular implants.
Yes.
The fact that it was made out of Perspex from the Spitfire jet, which what Ridley made it originally, was really the inspiration behind the implants. But the Perspex lenses have held up very well. Going to India's situation, in the earlier days, Shah and Shah used to make lenses.
Yeah.
Correct.
And he used to put in metal loops and then use surgical glue to stick them on. And some of those patients are still functioning well enough.
Yes.
So, I mean, you see a lot running through the years, and you see some of your long-time patients. I see Shepherd lenses quite often, and the lenses come surprisingly stable and good.
Correct.
So, I mean, I think the implant has really been a boon to everybody. And I think the biggest boon is to the rural person, not the urban person. Urban person can manage. Rural fellow, जब रास्ता ही ना ठीक तरह दिखे और 10 नंबर कांच के साथ वो काम क्या करेगा? For him, it made a world of difference.
Absolutely.
But I mean, life was interesting. I don't know the reasons I mentioned about retina was because My original boss was, am I running out of time? Can we wait 5 minutes?
Sir, yeah, no
Yes, sir.
problem.
I'll just tell you a little this thing. My original person who taught me ophthalmology was a guy by the name of Simon Franken. Simon Franken was a retina man. He was taught by Veve. And this was in Ludhiana Christian Medical College where I was there. And we used to make the loop from the hair of one of the staff nurses who had thick, long hair, which we used to utilize. Those were loops we used to utilize. So the first cases which I did were retina. When I went to London, I joined Peter Fison's unit in retina. I was in the retina unit for I think about 8 or 9 months, and then my boss Simon Franken's close friend was Binkhorst. Because the wife died in an accident, and because he was very depressed, so Franken told me, "You go and talk to him." I said, "Sir, I'm in now at Moorfields. I can't take leave and go away." Franken was emeritus professor at. So, an emeritus professor can do anything in London, literally. So he said, "You can take 1 month's leave and go and see Binkhorst." So I went to Binkhorst. Those of you who know Binkhorst, Binkhorst was a fellow who enjoyed sailing, and he had a little dinghy in the port there, and we used to go for sailing. And the idea of sailing is that they tied you to the mast, so you didn't fly off the boat. And then you went to the ice cold water and you came out after 2 hours, and he would say, "Didn't you enjoy yourself?" And you, being the junior, will say, "Yes, sir, it was very nice." मन तो कर रहा था कि कहने का कहाँ मरवा रहे. Either way, at the end of I was Binkhorst when seeing all his lenses, and the end of it, it turns out and says, "You are wasted in the retina. You now go to anterior segment." I said, "I can't turn to anterior segment. I'm working in the retina." He said, "I've already spoken to Stallard and shifted you." You remember Stallard, apna? So that is how I went to the anterior segment. So these things fluctuate up and down. And go on.
Sir, one more question. Many times there are many astute clinicians, but they are not successful. So you are academician as well as successful practitioner. So what are the tips you can give to our new surgeons who are
Nothing. You see, you can only get a good referral practice provided you manage to get good results. You do the best for your patient. If you do the best for your patient, the patients know you're trying your best for them, and they stay with you. Otherwise, after a certain age, people don't come to you. The fact that my practice is still full indicates that maybe I'm doing something proper in life. But the answer is simple. Be at the cutting edge, learn all the new techniques, do the best you can, and you will survive. There's no question about it.
So learning, and learning, always.
The word learn indicates effort.
Yeah.
It's not learning. You pick up new things. You should look forward to the other way around. Kal mein naya kya aa raha hai? I mean, that's how I look at it.
Looking forward to the new.
Yeah, you look forward to the day. That's why I said right in the beginning, when you're faced with a nice hard rock cataract, don't look at it and say, "Kahan yaar phas gaye subah subah." Look at it the other way around. Now you have a chance to do something great for that patient.
Attitude. Yes.
That's the way you look at it.
Really inspiring.
Very inspiring.
It's like, for example, when we used to give retrobulbar blocks. One of my bosses who was there in London turned around and said, "You tell the patient that when I give the injection, if it feels warm, then it's gone in the right place." So I looked at him and thought, kahan bol raha hai aise? The next time I gave a retrobulbar, because those days people who were working in the hospital only gave retrobulbars. They didn't let you touch patients at level. Retrobulbar diya. I told the patient, garam laga ke? I felt hot. The patient looked at me happily. "Yes, you've given it perfectly. I felt it beautifully." And I realized it's only a question of how you put it, which makes the difference.
Yes.
Absolutely true. Yes, sir. Yes. So, are there any other questions by any of our panelists or MOS team?
It's the patient focus, basically, which has been paramount with Sir. Do the best for your patients.
Yeah.
Always, continuously.
Absolutely. Yes.
like to thank MOS very much for this honor which they have given.
We really had a good time with you, sir.
Thank you
We
so
had a
much.
very good time, good evening today.
And learn so much.
And we
both.
learned so much.
Yes.
And
Absolutely.
it was my desire to have a legendary masterclass every month.
Yes.
So we can learn from our masters.
Absolutely.
In conferences, what happens, sir, for 8-minute talks, what we can learn from that legend in 8 minutes talk. So this is means lifelong your experiences we can learn from you. That's what my desire actually.
Absolutely. And also ophthalmology and pearls beyond ophthalmology. As a
Yes.
person, we
Yeah.
have learned so much from you. Your habit of reading every day, I think that
Yeah.
is probably the biggest take-home message.
The biggest take-home messages.
और कोई रास्ता नहीं है मेरे दोस्त और
There,
कोई
there
रास्ता
is,
नहीं.
there
You
is
have to
something more. There is something more. After all this, Keki is still grounded.
Yes,
Mm.
absolutely.
Never forget
Yeah.
that he is 100% grounded.
Absolutely.
Absolutely grounded. So that is a life lesson. That's something that you want to emulate in your life, all of you who are watching today.
Yeah.
Absolutely.
Definitely.
Thank you, Ranjit. Thank you.
Great. So I think
Thank
we will,
you, thank you, thank
will-
you, sir,
Quality
from the bottom of our heart.
thank
Thank
you.
Sir,
And
it's
for the
been a pleasure.
official vote of thanks, I would like to ask Secretary of Scientific Committee, Dr. Aditi, to please do the honors.
So first of all, I would like to thank Professor Dr. Kiki Mehta sir for inaugurating our MOS Legend series. I think it was a perfect start of the series. And as Dr. Agarwal sir mentioned, during our conferences, we just get to listen for 8 or maybe maximum 10 to 12 minutes. And that too mainly about the clinical things. So, but along with the clinical pearls, I guess even the life lessons and something beyond ophthalmology is the main thing which makes them legend along with the ophthalmology thing. So it was real a great opportunity to interact with Sir, and I would really like to thank him from bottom of our hearts from our team MOS. I would also like to thank our panelists, Dr. Modi sir, Dr. Maniyar sir, Dr. Kankaria sir, and Dr. Cyrus Mehta for joining us and sharing few experiences which they had with Dr. Professor Kiki Mehta sir. I would also like to thank our President Dr. Santosh Agarwal sir, our Secretary Dr. Atul Kadane sir, and Treasurer Dr. Mandar Paranspe sir for joining us and making the interaction much better. I would like to thank Entod people for giving us this platform to interact, and also would like to thank the technical team. Would also like to thank the viewers who joined us on Weblink and Facebook and YouTube, and obviously Dr. Vardhaman, who is the chairman scientific committee. So thank you all.
Thank you.
Who is the instrumental actually? Vardhaman is the instrumental to make it happen actually today.
Sir,
Thank you, Vardhaman and the MOS team.
for your support and guidance, Dr. Agarwal sir, always, and of course to the
Yeah,
whole team.
thank you.
Thank you again, Dr. Mehta sir, Dr.
Thank you
Mani.
very much, MOS. So kind
Yeah.
of.
Thank you, sir. Thank you, sir. Good night,
Thank
sir.
you. Thank you.
Thank
We
you.
enjoyed.
Thank you, sir.
Good night.
Thank
We
you.
enjoyed.
night.
We enjoyed.
Night.
Good night.